Good afternoon. Thank you all for inviting me to speak. I have to remember that it's been 30 years, I think, since my first ASAP meeting, at which time I met Bernard Williams, whose daughter is here today, and Don and Barbara White, who were the founders of this organization, were present. So it's been a long time coming, and I've enjoyed my association with this group very much. I'm going to talk this afternoon about primary spinal syringomyelia, and just by way of definition, what it is syringomyelia that originates from an abnormality in the spine as distinct from syringomyelia related to cerebellar tonsil descent or Chiari malformation. And I thought I would review briefly the pathophysiology so we all are on the same page understanding what is meant by this. As you've also heard earlier this morning, spinal fluid pulsates in all of us synchronously with our heartbeat and breathing. So there's normally a pulsation of cerebrospinal fluid that originates in the brain and pulsates down along the spinal canal. And when the pulsations encounter a partial obstruction to this flow, it becomes easier for the spinal fluid to enter into the spinal cord than to travel along the outer peel surface. And this is particularly true in patients who've had a spinal cord injury where the tissue itself is not whole anymore, but is disrupted. And partial obstructions of the flow to spinal fluid in the spinal canal may result from a spinal cord injury, which is the most common of these abnormalities, but even from surgery that was performed for the good surgical indication to go into the dural compartment. It is common in people who've had meningitis, in some people who've had bleeding into the subarachnoid space from either an injury or from a ruptured blood vessel, or sometimes even from foreign substances that were introduced years ago for imaging purposes, which are no longer in use, in part because they do evoke a reaction. Bone fragments and spine deformities can result in partial obstruction. Even a normal disc herniation in some people, in very small number of people, can result in this. Arachnoid membranes, which are developmental in origin or maybe post-traumatic in origin, can produce a partial obstruction to flow. And tumors, even benign tumors of the spinal canal, can result in a partial obstruction of CSF flow. So in that sense, syringomyelia of the primary spinal syringomyelia can be regarded as a symptom of subarachnoid stenosis. And I would be remiss in not mentioning that Dr. John Heiss, who joined us here today, was very instrumental in clarifying some of these relationships. So in that sense, the spinal subarachnoid space becomes a relatively isolated compartment, and this is true in Chiari cases where the tonsils produce this partial obstruction, and in traumatic scar in trauma cases. And by analogy, the treatment of post-traumatic syringomyelia, which we're going to focus on first, has to be directed at eliminating the partial CSF obstruction at the spinal level. MR scan is very good, but in many instances, even today, we resort to myelography and CT scan following a myelogram to look for an obstruction in the flow of contrast material that is injected into the spinal canal. And ideally, we may have to introduce contrast material both from the upper cervical region and the lumbar region in order to bracket, as you'll see in a moment, the obstruction. So myelography in that sense may be very helpful in defining what we do as surgeons. Particularly this is true when there is no identifiable scar or where there is a honeycombed syrinx. Sometimes it is very helpful in defining the limits of an arachnoid cyst. And as I indicated, sometimes it's necessary to do this with contrast introduced both above and below. We don't have very good other studies as we do in the cranial region, flow studies, for example. And for this reason, even today, and this is likely to change over time, we still find that myelography and CT scanning is the gold standard for defining absolutely how extensive a obstruction is. So we're going to talk briefly with some examples of syringomyelia as a complication of spine injury or so-called post-traumatic spinal cord cavitation. This is an example of a paper from Dr. Millerath, which shows you exactly how a spinal, I don't know, do I have a pointer here? Pointer works. But you can see the hole in the spinal cord from the injury and the syrinx that has formed and communicates in that way. And the typical aspects of post-traumatic cord cavitation is that the spinal trauma may have been trivial in the sense that all it needs to do is set up a mechanism for scar tissue formation. And I will say that not everybody has the same propensity to develop scar tissue following an injury or following blood in the subarachnoid space. This is a very individual thing and may have, as yet, not clearly defined genetic markers. It is also true that for the same reason, years may pass between the injury and the development of symptoms related to a syrinx formation because scar tissue forms, and with the additional stimulus of the pulsations may thicken and ultimately reach a point where it causes a partial obstruction of CSF flow. So sometimes patients go for years and they may even have a sensory level until one particular event occurs and they cough very hard or sneeze very hard, and all of a sudden the sensory level goes up, and that is a not uncommon manifestation. And this is from an old paper, but it still pertains that the initial symptoms are oftentimes pain on coughing, straining, or sneezing, spontaneous pain, awareness of spinothalamic loss, meaning loss of pain and temperature sensation and or temperature sensation in some part of the body. And for reasons due to autonomic innervation, there may be, patients may experience excessive sweating in the upper part of the body and none below the level of the injury. And very few patients do remain asymptomatic. The incidence of post-traumatic spinal cord syrinx formation has increased, it hasn't really increased, but our recognition of it has increased with the advent of MR scanning. It is important to understand why not every patient with a spinal cord injury develops syringomyelia. All of us are born with a central canal within the spinal cord. This is a normal part of our development. And as the child ages, this central canal, which here has normal lining of tissue, as the child ages, again for genetic markers not clearly identified so far, this central canal undergoes involution and disappears. But that said, this study, which came out of Japan, shows that while the patency of the central canal diminishes as we get older, in this particular population, even people in their 9th and 10th decades may still have a persistent central canal. And we don't know exactly why that is, but we do recognize that a persistent central canal is a now not uncommon finding on MR scanning. This is its typical appearance, and as you can see, it's sort of fusiform and has linear extension, oftentimes going up, sometimes going down, and the cord, the spinal cord itself, is minimally expanded by this cavity, if at all. Here's one that is in the lower spinal cord, again linear, with a little extension rostrally and caudally. And this is what it looks like on an axial image, a perfectly round central opening without any expansion of the spinal cord. And the distinction between this persistent central canal, which can be called hydromyelia, and syringomyelia is terribly important. And I can tell you that from my own practice, I see many patients who have a radiology report in their hand that says hydrosyringomyelia, or cannot exclude syringomyelia, and patients understandably become very concerned about this. But it is really terribly important, from my point of view, that radiologists be more accurate and more definite in making the correct diagnosis rather than trying to do a, let's say, legally more useful diagnosis. I next want to talk to you about a different type of primary spinal condition, congenital arachnoid cysts or diverticulae associated with syringomyelia. And here is an example of a syrinx. You can just see the syrinx cavity here. Oops. No. It's going wrong. There we are. In the cervical region. And here we used myelography to define the block. The needle was inserted up here. You can see the block. This is where the contrast stops. And what we saw at the time of surgery was this thickened arachnoid membrane, which we excised to reestablish normal flow of cerebrospinal fluid. And postoperatively, the syrinx disappeared. Here's another case. Again, you can see the syrinx cavity down here. And in this particular instance, the syrinx cavity stopped very abruptly at this level. And when we went in, we found that this patient had an arachnoid diverticulum into the subarachnoid space, and this pouch of normal tissue produced a blockade of spinal fluid circulation, which resulted in syringomyelia. And this is what we found at the time of surgery. Here we injected indigo carmine, which is no longer available, but was at that time, into this arachnoid pouch that was within the canal. And when we resected this, the syrinx cleared up. We can see post-traumatic syringomyelia with or without a bone deformity. As I said, it relates in large part to the propensity to develop scar tissue in an area of injury. And as you know, some people, even in their skin, have a tendency to develop proliferative scars with keloid formation, and other people do not. And we don't know all, we know some genetic aspects of this, but we don't know all of them. So in treating patients who have no obvious bone deformity, we do have to try to establish whether the subarachnoid stenosis is complete or incomplete, whether it's focal or diffuse, and particularly also where in the spinal canal the partial obstruction is. And as you'll see in a moment, if it is very high in the cervical region, it has a particular clinical significance. And once again, myelography may be helpful to define this. Rarely we have syringomyelia without any definable subarachnoid scar, and in those instances, even today, we need to resort to shunting or diverting the fluid out of the cystic cavity into some other body compartment from which it can be resorbed. So we're going to talk about focal arachnoid scarring, and here is a patient who was, again, studied, and you can see the syrinx cavity eccentric outside. It's very different from what I showed you before with the residual central canal. And in this instance, we used myelography to demonstrate the blockade, both with contrast introduced above and below, and we can tell exactly where our incision needs to be. And in this instance, we found an arachnoid scar, and we again used indigo carmine to demonstrate, and you can see that the flow of spinal fluid stops or is impaired abruptly at this level. Very dramatic presentation. And postoperatively, the syrinx collapsed. Here is another instance. And again, myelography was helpful in defining the blockade, which you can see right here. And this was an arachnoid cyst, which we were able to aspirate. And then at that time, we placed a dural graft, such as you've also heard referred to earlier in Chiari cases, sewn in here. And the syrinx collapsed. Bone deformities can produce compression of the subarachnoid space, and the bone deformities may occur high up in the cervical region, as we see here, and postoperatively the syrinx collapses, although it doesn't disappear, but it takes the tension off the spinal cord. And here's one in the lower lumbar region. Again, Here's the level of injury. And the syrinx extends both up and down, and then postoperatively, when we corrected the deformity as we did in those days, the syrinx becomes much smaller. As I mentioned before, syringomyelia can occur even if the surgery is performed for good reasons, such as tumor removal. And we can see a scar at the area where the tumor was removed. And diffuse scarring of the subarachnoid space, such as we can see in this patient who had a subarachnoid hemorrhage, we still have to shunt today because it is impossible to resect a scar of this type. High cervical lesions are a particular problem because if the injury to the spinal cord occurs in a high cervical region, a direct surgical approach may risk making a patient respirator dependent. Here's one such example. And here is what we have done for this particular patient. You can see the syrinx and where the cord was injured. And going into this level risks injury. And what we did in this patient was to divert the spinal fluid from above with a thiccoperitoneal shunt. So the shunt was placed, oops. I don't know why this has changed. Okay, the shunt was placed right there so as to diminish the pressure of CSF that would attach itself and penetrate into the cord. So subarachnoid shunts just rostral to the obstruction, reduce the filling pressure into the syrinx cavity, and this is just a. Here's another example of a patient who had a spinal cord tumor removed and developed a cystic cavity here, and we shunted from above, and the cystic cavity collapsed. I'm going to make a few brief comments about syrinx shunting, which, as I say, is still necessary in some instances, and it works. But syrinx shunts can become obstructed, and it is in the nature of a syrinx shunt that it, because it may become obstructed or scarred, that it may need to be revised once or many times. And one of the reasons is that if the shunt really works very well, tissue has a tendency to grow into the openings of the shunt and thereby occlude it. We actually developed a shunt tubing that reduces the likelihood of this happening, but because the market for this is very small, industry does not want to produce it. Poor shunt placement is a problem sometimes in people who have two parallel cavities and you don't know which one to shunt, or both. The shunt can act as a tether. The shunt can become infected. So there are lots of, and if it works very well and doesn't have a valve implanted, it can result in a low spinal fluid pressure state and has to be revised with a device inserted to reduce the direct drainage. So shunting should be considered as a last resort when all else fails. And I think my time is up. I will close at this point. Are there any questions? Thank you.